Buongiorno, signore e signore, signor moderatore. Agradezzo il gentile invito del professor Vincenzo Gasparro e mi scusa di non parlare italiano, lo voy a parlare in inglese. Well, Professor Gasparro invited me to talk about the new antithrombotic drugs in the perspective of a vascular surgeon dedicated to phlebology. I will divide my presentation in three parts. First, the arguments that support the rational use of these new antithrombotic drugs. Second, what we can expect from their use in the deep venous thrombosis and venous thromboembolism. And third, the most remarkable studies that can support the scientific evidence for clinical use. First argument, you all know, venous thromboembolism, it is so frequent. Second argument, the economic burden of venous thromboembolism on healthcare resources is substantial. And this is especially when you are talking about the costs concerning the recurrence. Third argument, the treatment duration, it is still uncertain, and this we already heard in this morning. This is more strong. The current evidence suggests that the risk of recurrence after stopping therapy is largely determined by two factors: whether the acute episode of venous thromboembolism has been effectively treated, and the patient's intrinsic risk of having a new episode of venous thromboembolism. Fourth argument, it is that we know that patients on prolonged treatment, the standard treatment with warfarin, for example, has had a lower risk of recurrence, but a high risk of bleeding complications. And last but not least argument, we all know the limitations of these vitamin cap antagonist drugs, the warfarin. So these six arguments can support the development of these new thrombotic drugs directed to acting specific coagulation factors named the factor 10A and thrombin. The rivaroxaban, apixaban, and exaban, and others for factor 10A, and Dabigatran and others for thrombin. What we can expect for these new groups of antithrombotic drugs? First, these new oral anticoagulants have predictable pharmacology with few interactions with few food or concomitant drugs, and the target, as I already said, a single coagulation factor. Second, they had a wide therapeutic window with no requirement for routine coagulation monitoring and can be used at fixed doses. For this, we can expect an improved efficacy and safety, an improved quality of life, and reduced administrative costs. We have several studies in the literature concerning this. You can see here. Comparing these new antithrombotic drugs with low molecular weight heparin, with warfarin, with placebo in acute phase after the standard therapy. Let me explain and show to you the results from the most remarkable studies in this field. First, EINSTEIN studies concerning the rivaroxaban compared with the standard therapy in acute phase with low molecular weight heparin plus warfarin, and the EINSTEIN extension compared with placebo. In the acute phase, the major outcomes are the primary efficacy symptomatic recurrent venous thromboembolism, comparing rivaroxaban with the standard therapy for 3, 6, or 12 months. And the principal safety outcome combination of major and clinical relevant bleeding. What were the results? For the efficacy, we can see an hazard ratio of 0.68. It is not statistically significant, but is clearly in favor of rivaroxaban comparing with the standard therapy. And for the principal safety outcome analysis, we have absolutely similar results with an hazard ratio of 0.97. So the conclusion of Einstein comparing rivaroxaban with standard therapy were a non-inferiority to the standard therapy for efficacy and similar findings for the principal safety outcome that it was major bleeding. The other part of extension of Einstein, the Einstein extension, compared rivaroxaban with placebo for a period of 6 to 12 months. And here, for the principal efficacy outcome, we can see a clear difference in favor of rivaroxaban with a rate of recurrence of 1.3 for rivaroxaban compared with the rate of recurrence for 7.1 for placebo. And concerning major bleeding, we have similar findings. No difference between the two treatments with a rate of 0.7% for rivaroxaban. And so the conclusions of Einstein extension were that we have an 82% of reduction of the relative risk reduction in the recurrence of VTA for the rivaroxaban, and we have a low incidence of major bleeding with this new antithrombotic drug. And concerning Dabigatran, it's a different group of these new drugs. The recovery studies compared the Dabigatran with the standard therapy. And we can see the major outcomes were similar. The efficacy, it was the recurrence, and safety, the major bleedings. In these studies, the recovery studies, the results were similar with no statistical difference for efficacy and for safety, as you can see here, with a risk difference of just 0.4%. So no difference. The use of Dabigatran in an extension period, it was called the Remedy study, compared this Dabigatran with placebo. And we have other study concerning the Dabigatran, the Resonate, a different study with the same outcomes that was compared in a period of 6 months. A new drug, I'm just now mentioned some of the important studies in the literature. You can see the results that are already published, and some are ongoing yet. Concerning the apixaban, we have the Amplify study, and also the Amplify extension. And let me just remember to you, and concerning the question that it was made in the last presentation, we have already supporting evidence for the use of these new antithrombotic drugs in orthopedic surgery. And it's important to remember to record studies with the use of rivaroxaban in knee and knee replacement. And also the importance of the use of these new antithrombotic drugs in the prevention of stroke in atrial fibrillation. And so, to finish my presentation, what can be our take-home message, the summary of this presentation? We all know that venous thromboembolism, it is still a serious and frequent problem. The current treatment, it have a duration that is still uncertain. Many of the patients we don't know if we must or not support a secondary prevention after the standard period of 6 to 12 months. We know that the use of the conventional warfarin therapy after the acute phase sometimes has a major bleeding as an important complications. And these newer antithrombotic drugs may have the potential to improve the benefit risk and simplify acute VTA treatment and secondary prevention besides the price. Thank you.